Thank you very much. And it's a real pleasure to be able to talk to everyone at this forum and to basically share a little bit of what I know and be able to answer some questions. So, to begin right off the bat, what is dementia? So, I'm going to start by saying dementia is a description, not a disease or a diagnosis. What do I mean by that? What I mean by that is imagine, if you will, we think that your brain probably started developing when you were in your mother's womb. In fact, we don't think we know this. And it probably finished developing sometime around when you were 26 years old. So if we can imagine, if we could all build a time machine and go back to where you were at 26 years old and essentially test your cognition, we would that number is going to be very variable across everyone in the world. But the bottom line is that for you, that was your sort of peak. And so we would call that your sort of where you are for normal cognition. And assuming things go well for you during your life, you should stay very close to that peak for the foreseeable future. So, what dementia is a definite thing where the peak is here, and now you're here. And we don't have any way using medical therapy to bring you back up to where you were before. Dementia is an irreversible loss of some degree of cognitive capacity, and in particular, to get more technical, it's a loss of enough capacity that you now need a little bit of help doing day-to-day things in your life. If you need a little bit of help, we say you have early dementia, and with more and more degrees of help, your stage increases from early dementia to moderate dementia to advanced dementia. There's also a stage a little bit before early dementia that we call mild cognitive impairment. And that is basically something where we do see some evidence that someone's cognition is below what we think their peak was, and we don't have any way of bringing it back. But that change has not yet led to people needing a lot of help to do their day-to-day activities, and it usually tends to be localized in one specific domain that we call cognition. There are different domains that we test. Your ability to remember words, your ability to remember pictures, your ability to use language, your ability to focus your attention, your ability to solve problems and divide your attention, your ability to look at the world and make a three-dimensional picture of it. All these different cognitive tasks are basically subsided in the brain, and we test all of those when we send people for specific testing. The other thing I will mention is that you can imagine that this process of testing has its own limitations and caveats. How do I really know without a time machine how you were doing when you were 26 years old? I don't. Neither do the people who are doing the testing. We have to make a lot of inferences. We're pretty good at this. But again, for subtle things, we can sometimes need to really think hard about the problem. So that's dementia. Dementia is a irreversible loss of cognitive capacity that leads you to have some kind of day-to-day need that's required for you to be able to go on and that you can't do on your own. So there's lots of different ways you can get dementia. And this is where people can get confused. Depending on your age, there's different things that are more likely. So for people in their late 60s and 70s, by far the most common cause is something that we'll talk about a bit, Alzheimer's disease. It can also be vascular disease, and these are different kinds of processes that can cause dementia. There are some very unusual causes that we only occasionally see in clinic. You may hear some names like frontotemporal dementia or semantic dementia. There are problems that we think are probably more prevalent, and we're only really beginning to understand them now. For example, issues like chronic traumatic encephalopathy and roles of how other diseases that people have had throughout their life may contribute to cognitive loss. So the bottom line is that while dementia is a description, there's lots of different ways that you can get to ultimately having dementia. The other thing I'm going to mention here is that really we don't have a good scientific understanding that we can base effective curative therapy on for any of the causes of dementia, even the ones that we've kind of known for a long time and have some pretty good thoughts about. So, for example, if in a very broad way of looking at the world, you can classify the causes of dementia into two very broad buckets. One bucket is your brain is greedy. It always wants blood flow. So any process that interferes with getting your brain blood flow has the potential to cause dementia. We call these vascular problems, and they can be everything from strokes, which a lot of people are familiar with. And a stroke in the right part of the brain can lead people to mild cognitive impairment or dementia. And certainly multiple strokes help speed that process along. But there are other problems. There are problems where the actual small blood vessels don't work properly. It's not necessarily that they're clogged or that they're clotted, but their function in the tissue, being able to essentially hand off nutrients like oxygen and sugar, glucose, to the brain cells is impaired. And that process is very, very specific. The brain cells are very greedy. They want what they want. And if you don't give them what they want, they don't function properly. So even something simple that we understand, like vascular disease, which we know the risk factors, high blood pressure, high cholesterol, tobacco use, uncontrolled diabetes. Um, Even when we get those risk factors under control, we can slow down and usually stop the progression of vascular disease. But we don't know how to actually go into those blood vessels and convince them that everything is a-okay now and they can start functioning normally. That's still beyond us. So, and that's the lowest hanging fruit on the tree for us. So we don't even know how to really reverse this problem that we understand the best. And as we go through some of the other problems, well, it's even more and more difficult. So as I said, I think about things sometimes very generally in two buckets, the vascular problems, then there are problems that I call neurodegenerative. So what the neurodegenerative problems are is basically the actual cells within the brain are being lost at a rate far greater than we would expect from aging alone. That kind of brings me to, well, what happens in my aging brain? And that's a very good question. We still don't fully understand what normal aging in the brain looks like. There are certain things we clearly know. So, for example, I can tell you that if you could take an MRI of me when I was 40, I actually have one. I had to one day dig it out from the University of Nebraska Medical Center's radiology library. And if I repeat that MRI when I turn 75, my brain will have definitely shrunk. That is an expectation. Everyone who's alive, if they are lucky enough to live to be older than 65, will ultimately experience some degree of normal brain shrinkage, normal, what we call a little bit of cortical atrophy, and that is expected. The question is, again, how much? I expect a little cortical atrophy, not a lot, not a huge amount in one particular region of the brain that might be accelerated compared to other regions of the brain. So when I look at these neurodegenerative problems, we're always asking ourselves, how much different is this from normal aging? And these degenerative problems are very, very tricky. These are the diseases like Alzheimer's disease, Lewy body disease. There's a new one that we've just learned about in the last 6 years called limbic predominant age-related TDP-43 encephalopathy, and we abbreviate that mouthful as LATE. All of these are problems where the cells of the brain, the actual neurons, the cells that are doing the computations, are being lost at an accelerated rate. We have no clue how that's happening. And I really mean we don't have a clue. We have a lot of hints, but we do not actually have what we would call a pathophysiological mechanism, some way of going from A to B to C to D that allows us to track what's going on and ultimately determine therapies that can stop this disease process. This is one of the very frustrating things about problems that are affecting memories that we don't really know at a very, very basic level how to address these problems. We know a lot about what is sort of accompanying them, but the actual switches that are being thrown when things kind of go off the rails, we don't know that yet. So basically, I've sort of mentioned a couple of the causes. For what it's worth, we think that probably these sorts of um, problems that lead to dementia ultimately affect probably close to 20% of people in their 70s and over 50% of people in their 80s. Alzheimer's disease, for example, which is responsible for a little bit more than a majority of the problems that we'll see, affects about 12% of people in their early 70s as a general rule, and about a little bit around 50% of people in their mid 80s. Vascular disease is also a very significant cause. We see a lot of that as well. The other causes are present, and we see them in clinic, but not nearly as frequent as sort of the big two that we tend to see. Just to give you some numbers to give you an idea of exactly what kind of deal we're dealing with and how kind of the deficit really impacts us on a day-to-day basis. Right now, right now, around our country, there's about 7 million people who have Alzheimer's disease. And we think that in 25 years, that number is almost going to double to 13 million people. Right now, Alzheimer's disease is the fifth leading cause of death of people older than 65. And we are spending right now $360 billion a year in Alzheimer's care. And if we don't do things to change things, by 2040 to 2050, that's going to be closer to $1 trillion a year just for Alzheimer's disease and dementia alone. Um, Alzheimer's disease has an impact on families. There's over 11, for those 7 million people who have Alzheimer's disease, there's 11 million people who are usually family members who are helping provide unpaid care for these people. And a lot of these folks, because they haven't been given the kinds of training and let's not kid ourselves. Our media does not really show very much about what the actual care of people who have dementia looks like. So we don't see a lot of caregiving in movies or in TV shows. And so people are kind of making it up on an individual basis, one family at a time. And for a lot of people, that is extremely stressful, and it leads to increased risks of depression in caregivers. Caregivers' own health is much worse. This has been proven in a number of studies than people who are the same age and have the same medical problems, but who are not caregivers. And we are still, as a system, struggling, trying to do a better job for caring with these patients. At the end of the talk, I'm going to talk a little bit about an answer that the system has come up with and spend a little time with it, because I actually think that this is probably some of the best news we've had in care of persons with dementia in the last 30 years. So we've kind of talked about dementia. We've talked about certain different causes of dementia, particularly problems either getting blood flow to your brain or problems with accelerated loss of cells in the brain. If you don't have dementia, what can you do not to get it? There's a lot of lifestyle things that people can do right off the bat that lower their risk of getting dementia. I can't take your risk to zero. There's nothing we can do right now that will take our risk of dementia to zero, but there are certainly lifestyle things that we can incorporate into our own day-to-day lives that are not onerous and really unachievable, that can lower risk of dementia. So the very first things I tell patients is deal with your vascular risk factors. So, we need to make sure that people stop smoking. We want to make sure that people, if they have high blood pressure, have that blood pressure under control from their internist. If they have high cholesterol, we want to bring that cholesterol under control. If they have high blood sugars, we want to bring their blood sugar under control. I want people to exercise. And when I say exercise, I'm not talking about the kind of exercise where we are training for the Olympics or training for an ultra marathon. That's nice. And for people who are 65 or older who can actually exercise at that kind of, elite athlete performance, I give them all the more power. But really, what the brain is looking for is activity. It's not looking for super activity. It's just looking for about 20 to 25 minutes of moderate activity on a day-to-day basis. So when you go and take a 25-minute walk with your dog in the morning or in the afternoon, and you come back and you haven't run with your dog, you haven't really worked up a lot of sweat, that 25 minutes of activity is essentially enough to trigger certain processes in your brain that we think preserve those brain cells. And it is well shown that exercise is right now the only therapy we have that actually really can reverse the cell loss that these neurodegenerative processes can cause. And exercise with controlling vascular risk factors improves the tone of the heart, improves the tone of the blood vessels, and puts the brain in a position where you freeze that vascular disease in place. And in some people, we even can see, although we don't fully understand why, some regression in their vascular lesions. So, treat problems that we know cause things. Exercise is another thing. The next thing I tell people is, you know, do a reasonable diet. And what I mean by a reasonable diet is any kind of diet that is basically low in saturated fats, has appropriate portion sizes of proteins like fish, meat, chicken, even pork. And we're talking about a portion size that's about the size of a deck of cards. I ask people to eat colorfully. And what that means is greens from spinach or salad on your plate, reds from tomatoes and peppers, oranges from carrots, yellows from other peppers, from corn. I want people having a diet that has, I want everyone to have at least two vegetable dishes on that plate in the evening to help them maintain a good Mediterranean style diet. And in general, I like to see people, basically grilling or baking or broiling foods as opposed to frying them in oil. And that's just to lower the overall fat content that we're dealing with. Does that mean you can never, ever, ever have anything that is fried? No. Again, our lives are very, very short. We want to enjoy them. But what it means is that I, these are indulgences. And just like we don't want to indulge ourselves in too much cake, alcohol, or anything else at any one time. We want to be careful with how we indulge ourselves with our food. The last thing I tell people is make your life interesting. So there's a few, and what that means is, first of all, particularly for older adults, get your hearing checked. Because one thing that has clearly been shown is that if you can't hear what other people are saying, then the systems in your brain that actually organize your ability to process sound information start to degenerate. And when those systems degenerate, they don't come back. And you're not going to be able to understand people as well in the future just because you can't hear so well. So I'm very, very strongly encourage people get to an audiologist, get them to assess your hearing. If you need a hearing aid, use it. Really use it. Hearing aids do you no good when they're on the bed, the bedroom drawer and the bedroom dresser. And it's been shown that people, when they use their hearing aids, will have and can hear better, preserve their cognition. Another thing I tell people similarly, get your eyes checked. I want you being able to read and I want you being able to look around. And if things are blurry, you're not going to do those activities as well. And again, the part of your brain that processes this information is going to be more likely to not be protected by use. I also tell people, in terms of general things, to be social. Human beings are very, very, we evolved for a social situation, for social situations. Prolonged times living by ourselves are really, really not good for us. And we can sort of see this. I mean, as we can't, we're not that far away from the COVID epidemic that we kind of remember what it was like to kind of hunker down in our homes and not really go out with friends and colleagues for pleasure and for work. And for people who are living by themselves when that happened, this was a real problem. This was a real thing that actually, I think, had a real impacts on people's memory and cognition over that period of time. And it sort of really underlined the fact that we need to be social. And now that we're not living in pandemic times, we need to go out and hang out with our friends and our colleagues and our family and our neighbors and enjoy their company. Another thing that I think we need to make sure of, that I ask people to protect their health, is to take care of their mood. And what that means is we know that depression is a significant cause of cognitive changes in older adults. And in fact, in a lot of older adults, depression can actually look just like cognitive impairments. So I encourage people and I encourage families to be on the lookout for depression in their older loved ones. And if they see depression, this is something that can be treated in a variety of different arenas. Primary care doctors have the skills and the training to treat depression. Severe depression can go to behavioral medicine trained physicians. The bottom line is I want people who have depression to have some kind of therapy because when we treat the depression, people really do better. They really do better. And it can be pretty stunning how well they do if we get their depression under better control. Another thing I look at when I'm sort of thinking about what can you do to prevent things from getting worse is something called sleep apnea. So, how do you know you have sleep apnea? Well, if you have a sleep partner who's basically telling you that you snore and it sounds like a freight train, except for those periods of time where you stop breathing for 20 to 40 seconds, and then when you start breathing again, it sounds like a small, a valve is blown. Those are the sounds of sleep apnea. And we see a lot more sleep apnea now than we did 40 years ago, partially because there's more obesity, and with obesity comes more fat around the neck, which can sort of help sleep apnea progress, and also it changes a little bit how our brains control our sleep cycles. And of course, this is when people are getting older, sleep apnea is something that can occur with aging. If people have this problem, I encourage them to basically either get their regular doctor. If they're in my clinic, we order a sleep study. These things can be done at home. And the things I love about sleep studies is that they give usually they give a pretty unambiguous answer. And the treatment for sleep apnea usually is pretty straightforward. We give people a CPAP machine and they learn how to use it at home, and that keeps their airways open so that they're always breathing comfortably throughout the day. Again, the problem with sleep apnea is when you fall asleep, your airway shuts off. It literally pinches closed. And when you're breathing, you don't pass any air between the outside world and your lungs. There's only so much air in your lungs. With about 20 or 30 seconds of your heart beating, your body effectively deoxygenates all the air that's in your lungs. And then the concentration of oxygen in your bloodstream starts to fall. And your brain does not like that. First of all, because your brain needs to sleep at night in order to actually incorporate memories properly. And second of all, there's all sorts of secondary changes that go on in your body from that process that are not good for your brain either. A lot of people sort of have memories of their family from a generation ahead getting CPAP, and they think of it, they look, I'm not going to do that. That looked like a deep sea diving system. And I encourage you to look again because in the last 30 years, the folks who are doing that sort of treatment have really gotten a much more sleek package together that is much easier to tolerate, much easier to wear, and is generally much easier to adhere to over long periods of time. Finally, how do you keep your brain good? I tell people you need to keep it active. And that's different for everybody. So you need to find what works for you. What are the things I advise people to do? I advise people, if you like crossword puzzles, do a crossword puzzle and challenge yourself. If you like Sudoku, do a Sudoku. If you like other kinds of word or number games, do those. If you like C&W music, put on put on, Johnny Cash, put on someone who you really like and listen and enjoy. If you like art, go to the local gallery and enjoy work from people that you're not familiar with. If you like theater, go to small plays, go to larger theatrical plays, but basically go out and do something that challenges your brain is out of the rut, something that's not just sitting and watching television. I want people engaged in an experience. And that process turns on all sorts of different parts of your brain that, again, through activity, helps preserve the circuits that are most at risk for being lost in these sorts of neurodegenerative and neurovascular processes. So, what happens if you have dementia? Well, it depends. I'm actually going to kind of skip therapies or skip medical therapies today, partially because I think that when I want to talk about therapies, I think that's going to be more in a patient encounter setting and not necessarily in sort of a more broad public setting. And also, really, to be honest with you, if we had really great therapies for dementia, that would be a different thing. But the truth is the therapies that we have for the different processes, with the exception of the different therapies I would use to control your vascular risk factors, if you have vascular disease, are not are not as efficacious as we would like them to be or as we need them to be. So, and that problem actually was recognized by Medicare more than 10 years ago. And in fact, at that time, the leadership of Medicare went to the leadership of NIH and said, how are we doing with cures for Alzheimer's disease and dementia? And Francis Collins got back to them saying, not well. We don't really have a whole lot for you. We've spent a lot of money and we know a lot more about what's going on, but we're still nowhere near a cure. So what do you do when you don't have a cure and you have a problem that progressively gets worse with time, that people are at risk for when they get old just by getting older, and that ultimately requires a lot of help from families and other support systems in order to allow people to be able to stay at home? That was a challenge. And the reason it's a challenge is imagine, going to your primary care doctor. So your primary care doctor right now, and I'm going to say this as a guy who's boarded in internal medicine, who did an internal medicine categorical residency way back in the day, who practiced primary care as an internist for most of my career. So I am not trying to harsh on internists. It's my tribe, it's my group. But the way an internal medicine practice is set up is not a good setup for dementia care. We assume that our patients are able to talk to us and that what they're saying is an accurate reflection of what's going on in their lives. We assume that when we give them counseling, that they're going to remember what we're talking about. We also assume that they can pretty quickly answer our questions for us and pretty quickly participate in parts of the examination. And we even make even greater assumptions. We assume that they can make an appointment. We assume that when they make the appointment, they're going to keep it. We assume that they can get transportation from their job or from their home to make this appointment. All of those assumptions are out the window when you start developing anything more than really early dementia. And all of those processes need to take a lot longer. Well, you're scheduled for a 20-minute appointment. It may take someone 10 minutes of that appointment just to go through their medications. And now all of a sudden, up's got to go. Next patient's coming. This is not good care. In fact, this is lousy care. And unfortunately, the model of how we practice in sort of these community practices, that is the model. It is not built for patients who have dementia. So what Medicare thought is, well, what do we do? Well, how do we need to change the model in order to give us better outcomes for dementia? That's what I'm going to spend the last sort of 20 minutes of this talk about. Um, Medicare, to its credit, about 10 years ago, funded a series of programs trying to ask that question, what do we do to really get good dementia care that works for families and patients? Now, I will be honest with you, Medicare is also they've got a lot of flesh in the game. As I mentioned earlier, right now they are spending close to $360 billion a year on dementia care, and they have every reason to believe that by 2040, that number is going to be close to $1 trillion. And they are asking, and I think very legitimately, where is that $1 trillion going to come from? We can't, we can't continue the way things are going. Status quo is absolutely not feasible. So what they did is they asked a number of different institutions to kind of rethink what dementia care should look like. And after years of research, of articles being published and presented to to scientific and clinical peers and pretty rigorously debated and argued about, and you know a lot of you know a lot of the sort of things that happen with good science. A year ago, Medicare came out with a plan called GUIDE. And I'll be honest with you, GUIDE is an acronym, but I can never remember the actual. It's like guiding and something experience in dementia care. But the bottom line is what GUIDE is a program that CMS is going to start. Actually, they have started it in 13 institutions around the country, but that number on July 1st is going to increase to about 400. And Baystate is an institution that is going to have one of these GUIDE programs. And what basically Medicare has said is we have, I think, a consensus about what good dementia care looks like, what we think that's going to buy us, and how we want to operationalize it. So what is it going to buy us? Well, it's not a cure. We don't have cures. But what this is a program that is meant to do two big things. It's first of all meant to kind of improve the lives of people who have dementia. It's meant to improve their quality of life. It's meant to improve their safety, and in particular, their medication safety. It's meant to improve what we call their advanced directives. I think people and families will sit down and ask themselves difficult questions. What is the end of my life going to look like? Where am I going to die? Who is going to be there? And often people, when they work with their families, and these are difficult conversations, but often people have thoughts, I don't want to die in a nursing home. I don't want to die in a hospital. I don't want to die in an emergency room. I want to die in my bedroom. I've lived in this house for 40 years. I want to die in my bedroom. Okay, that's a really legitimate thing to ask for. The question is, can we make it happen? Because we know that often when something happens medically and the paramedics show up at your home, you're now out of your bedroom on a stretcher and on your way to the emergency room and a hospitalization where people may die. So we want to see, can we make the program in such a way that people's preferences for how they want to live the last moments of their life are respected? And finally, and this is why Medicare wants to do this. Can we not only improve, oh, sorry, before we go finally, another thing we want to do is improve caregivers' lives. Caregivers are super stressed out. Earlier alluded to that. We need to do something that allows caregivers to be more resilient and to feel a lot less stress. We need to provide them with support. And when we can support caregivers and they feel a little bit less like they're out on their own all by themselves, then really cool things happen. Like caregivers look at caregiving in a very different way. They're happier to do it for longer periods of time. And people, when they finally, if they end up having actually going to a long-term care facility, it's at a much more advanced stage than it might have been. And the last thing Medicare is trying to do with these things is sort of the reason that they got into the game to begin with. They want to save money. They don't want to spend money on things that are not really improving people's quality of life, improving care. We don't want to pour money down the drain. And when you look at all these programs, what we found is that if you do a certain set of things, and I'm going to start to mention what these things are momentarily, that actually you get these outcomes. You're actually able to succeed in all these tasks that I just outlined. So what does this look like? Well, the first thing it looks like is it doesn't look like something that's done mostly at a medical office. Most of these programs have recognized that really the appropriate place to provide most care for patients with dementia is in their home. That doesn't mean we're going to be sending a lot of people to their home. That's unfortunately difficult to do in a country the size of the United States with the population kind of skewed as it is in the United States. But fortunately, we have a lot of telecommunication capacity, and caregivers have proven that they enjoy talking to folks on the phone as much as the next person does. So one of the things that this program sort of incorporates is the ability to leverage telecommunication technologies wherever possible to provide caregivers and the people they're taking care of with immediate, as close to immediate as we can get support. And so what that means is not only providing caregivers with education, providing them with with advice. I mean, I will mention this a little bit later, but when someone calls you up on the phone going, "Mom has just thrown a dish at the wall because she doesn't want to take a bath. What am I going to do?" We need to give you real advice. Education at that time is nice, but really what we need to do is give you a couple step plan for how to de-escalate the situation and move forward. So education, advice, follow up. and basically making sure that there's a number of tasks that need to be done in order to make sure that we proactively plan for what the future looks like. And there's no time like the present to do this proactive planning. So that we're going to be checking out the things that we know are going to probably be problems in the future. Simple problems that you all probably are already familiar with. When mom and dad are not able to make decisions anymore because their dementia is so advanced, I need a smooth way of being able to manage their money, being able to protect them from scammers, being able to make sure that their bills are still being able to be paid. So we want to make sure right off the bat that we're doing things like durable powers of attorney, durable financial instruments, making sure that the decision makers are in place long before we need them, because ultimately we are going to need them. And we want to not be, this is a time when it's not useful to have the family and trying to make a last minute decision. We want those decisions made long before this event comes up on the road. So what does this program looks like? Well, I'm going to say that the special sauce of this program is a person who actually has only recently kind of have a role in our healthcare system, someone that we call a care navigator or care team navigator. And the great thing about the care navigator and the care team navigator is that in a time where I think a lot of folks would argue, I call my doctor's office and I will never ever speak to him. There's so many levels of people between me and my doctor that I don't even bother trying to call because I'm never going to get him. The navigator is someone who knows about you, knows about your loved one's medical problems and dementia at a really, really detailed level, and who you can basically pick up the phone and call without any intermediary from during the business hours of the day. That is phenomenally useful. We did a program like this when I was in a different position. And what I can tell you is that of the 3,000 caregivers we worked with, by far, the navigator was the special sauce that made this work. Our clients were not sending me or my nurse hand knitted sweaters and cookies and cupcakes and Christmas. They were sending that to the navigators because it was the navigators who really made a difference in their lives. And the reason why is that the navigators got to know them. It takes a little time. As humans outside of our family, it takes us a little bit of time to feel comfortable with other people. But once that comfort comes in, and it does, because we choose our navigators particularly to be the kinds of people who are kind and empathetic and and you feel when you talk to them, this person really wants to help out. That's part of who they are. Well, the navigators get to know you, and they get to know you, and they get to know their what we call their dyad, the person who has dementia and the person who's helping care for them. The navigators get to know the dyad, and ultimately they get to know the dyad so well that the caregiver feels really comfortable asking the navigator all sorts of questions that they wouldn't have felt so comfortable asking a nurse or someone else, because it's like, well, this probably is wasting your time. You'd be surprised how many times these little things that came up to our navigators made a huge difference for the patients they're being cared for. So it opens up access. And so these navigators provide long-term follow-through. Now they're working with teams. They're working with a team of nurses, social workers. There's a physician or a nurse practitioner at the very top of this hierarchy. There's also, as these teams get a little bit better, can include things like occupational therapists, recreational therapists, people who can help with respite care. But basically, this longitudinal care of people with someone who's trained to understand dementia, trained to know how to deliver the sorts of advice that that families dealing with dementia need, and trained to know where are questions where I need to ask the nurse or the social worker. These people are basically a widget that currently doesn't exist in the healthcare system that is really, really, really important. Um, I'll capture. I noticed that there's a question about training these navigators. I'll capture that when we go to the Q&A, but that's great. That's a great question. So in addition to the navigators, we need to have access when the navigators aren't around. That's another part of what Guide is going to offer, 24/7 access to someone who is actually going to have access to the records and be able to give families advice at 4 in the morning that they can use, as well as coordinate with the team the following morning and tell the navigator, you need to call this patient because they had a bad night last night. Another thing that kind of comes off that I think is pretty self-evident is we need to provide comprehensive assessments for patients to get started. Currently, our clinic does something like this already, and this is going to be formalized as an offering of the guide program. These assessments are done by either a nurse practitioner or a physician. And they're basically meant to identify exactly what are all of the issues that when we develop a care plan, we need to address, and what are the sorts of initial steps we're going to need to address these issues. And that document, as I said, converted into a care plan, which is basically kind of the roadmap of what we want to offer these families and these patients in the coming future. And basically the team spends a lot of their time going through what does the care plan say? What kind of progress are we at implementing the care plan and working with the navigators to make sure that the parts of the care plan the navigators can deliver are going off without a hitch, and the parts of the care plan that the navigators can't deliver are being delivered in some alternative way. Another thing that the guide program needs is basically what we call care coordination. And what that is someone with dementia is probably got a primary physician. They may have a cardiologist. They probably have an ophthalmologist. They may have a nephrologist. Depending on their medical problems, there may be a half a dozen or more different clinicians who are caring for this patient. Every health system, even the most integrated health systems out there, have always had issues with how do we communicate Steve's findings to the cardiologist? Because basically, after I'm seeing that patient and writing the note and saving it to the electronic medical record, unless that cardiologist comes up as someone I can immediately address it to, they we don't have the time to actually hunt down who that person is and send it out. That's a failing. I totally get that. But unfortunately, it's also a reality. And even with the advent of these electronic medical records that cost a king's fortune to implement in different hospitals, try sending data on your father who is being taken care of right now at Baystate, a CIS system, to the University of Wisconsin, a EPIC system. Good luck with that. Even though we have these electronic records, they don't talk to each other. I could spend an hour ranting about why that's the case and why we're not smart to prevent that from happening, but I'm going to spare you that. But the bottom line is we need to do care coordination. And basically, Guide pays people to do care coordination to make sure that if someone is leaving a nursing home or a rehab facility, everyone knows. And all the records are spread around to people. And if someone needs to have a nurse come and check someone's blood pressure or blood oxygenation, someone's making sure that that thing is happening. Coordinating care all across the system. That's something that is particularly important when people who have dementia, because again, the caregivers are often a little overwhelmed and the patients can't keep track of this. So one of the other things we do is care coordination. Related to care coordination, but different, is to be able is the ability to identify community supports. We are fortunate. We live in states like Massachusetts and Connecticut, where where the state government has a real appreciation that one of the functions of governance is to provide services for its citizens. The issue is that these services are complicated. They're sometimes difficult to access, and it's not necessarily straightforward. How do you go about getting your mom to get hooked up for Meals on Wheels? That's an easier one. Harder ones are things like how do you get someone on waivers for different financial programs? A lot harder. This is some task that is often has clinic social workers to do. And I'll mention those primary practices that I worked at for years never had a social worker involved. So Guide supports very specifically to have someone out there who is going to provide basically access to families to be able to support all of the services in their communities. And you can imagine that is not a easy task. The services you can get in Westfield are really different than the services you can get in Palmer, that are really different than the services you can get in Springfield, that are really different from the services you can get in Greenfield. And don't get me talking about what you might be able to get in the Berkshires. So this sort of thing is very, very hard. Most places don't do it because it's hard. Guide basically says we're going to pay money to make sure that this happens. An additional thing that needs to happen is we need to provide education. Because again, turn on the TV. Do you see any shows on Netflix or on HBO Max that basically are talking about dementia care? I don't think so. We need to be able to provide education to families and to patients to tell them what do things look like and answer their questions. Because again, you might be the internet's got all sorts of things on it. And it's hard if you don't have medical training to know if you Google something, is this really a true thing or is this basically another crank in this and their opinion on what to do that has very little substance in terms of data or research support. So Guide is meant to provide education. And finally, you know, at the end of the day, caregiving is exhausting. It's really, really tiring for families, for caregivers, and life intrudes. You know, a woman may be taking care of her husband, and all of a sudden her sister, who lives in British Columbia, is sick and she needs to go visit her at the hospital. What do you do? Well, what you do is you get respite. We basically Guide demands that we provide services to families so that the caregiver can leave for a brief period of time and we will have someone else to be able to provide care for that patient at the level that they're accustomed while that caregiver is gone. Now, you've heard all these great things and you're probably asking, how the heck are they going to do that? Well, what they're going to do is they're going to do something we should have done years ago, but we never had the guts to. Guide is not going to pay us for what we do. If you work with me, you will say that you will hear that I will use the phrase running the hamster wheel. Every time the hamster wheel spins, dollars come out. And so the faster you spin the hamster wheel, the more money comes out. That is our current system of how Baystate gets paid. Do you notice that the word keeping someone healthy doesn't come into the idea of spinning the hamster wheel? What Guide pays you for is basically providing the care. Doesn't tell you how much. Guide doesn't tell you how many navigators you need to hire. Guide doesn't tell you anything about other than providing these services. Guide gives you complete freedom to implement them. And what Guide basically says is, we are going to assess everyone who you enroll and ask, how complicated are they? And if they're really complicated, we're going to give you more money every month to take care of this person. And if they're less complicated, we're going to give you a little less. And at the end of the day, one navigator is going to be able to handle X number of patients, and you should be able to predict how much Medicare support you're going to get to manage those patients. And that is how this gets paid for. And the reason I can tell you that the Medicare was very excited to do this is when we did the trial, the patients who received a guide-like intervention cost Medicare on average $400 to $550 less per patient per month than the patients who didn't get Guide. So the question that I brought up earlier, how do we not spend $1 trillion on dementia care? Guide is Medicare's first answer to that question. If we can save $200 to $300, maybe even more per patient per month, we may not have to spend $1 trillion by the time it comes to 2040. So those are the kinds of services that Guide is providing, and those are the kinds of those are the what am I going to tell you? I guess the one thing I should mention is, as I said, Guide comes from basically, Guide has a number of fathers. It has fathers at the University of California, Los Angeles, University of California, San Francisco, and the University of Nebraska Medical Center, Johns Hopkins University, and the University of Indiana. And what they found when they did these tests is that if you do something like this, what happens? Patients with dementia show up in the emergency room less frequently. The caregivers of patients with dementia have less depression. For the first 6 months of taking care, the caregivers actually feel much more supported and feel like they know what they're doing, more so than the caregivers who don't have that support. The patients who are showing up in the emergency room, their caregivers are feeling less stressed. The patients who are getting medications are getting a much safer set of medications with lower drugs that we know cause problems in older adults and particularly adults who have dementia compared to patients who did not get this therapy. We also know that if you stated your advanced directives, your advanced preferences for what your end of life would look like, if you were in these programs, you were far more likely to actually see those preferences come true than if you were not. Additionally, the patients in these programs tended to be functionally more robust. They were able to get more exercise because the caregivers were able to provide it and were given the support to do so. And therefore, they were able to stay at home longer. And so the amount of time delayed going into nursing homes was significant in the patients who received this intervention compared to patients who did not. Finally, at the University of Indiana, they found that this worked even in patients who were experiencing what everyone would agree on would be a significant degree of poverty, a very disadvantaged financial condition, and a lot of disenfranchisement from the medical system. So this works even in what I would argue are some of the most difficult patients that we see on a day-to-day basis to care for. And finally, as I mentioned to you, it costs less. So this is one of those really rare things in clinical medicine where you get a win for the patients, a win for the systems, and a win for CMS. And I say a win for the systems because basically, not only is Medicare going to, if we don't do anything, is it going to cost CMS a huge amount of money? The medical systems can't afford to do standard care. It is literally too expensive. And a lot of programs are getting closed or being downgraded around the country because people look at it and go, we can't afford this. This is a financially sustainable model to move dementia care forward for the next 40 to 50 years. One day we may find cures for this. And I can tell you there's no one hoping for that day more ardently than myself. But until then, this is a really terrific way of improving the lives of literally millions of people in this country and doing so in a way that actually a system can, like Baystate, can pull off and that we can replicate literally in hundreds and hundreds of places across the country. So with that, I'm going to finish the talk part and basically kind of begin answering questions. And so the first thing I'm going to answer is a question that was asked at 6:29. Any advice about driving and when one shouldn't drive? It's a great question. What I would say is one of two things. Usually you can, there's a number of things that you can look for that are hints that someone is having difficulty driving. You will see sometimes problem maintaining attention. You will see issues where people confuse the gas pedal and the brake pedal. They have what we call an apraxia, and they use the wrong limb to do the wrong things. Their attention is wandering. They are not able to multi-track. In some specific kinds of dementia, their ability to judge distances, their ability to judge speeds becomes a problem. You may begin to notice this by a little bit more bumps and bangs and maybe someone pulling people over for issues. And you may just notice when you're driving with someone that your dad, who you used to feel pretty comfortable driving with, is now making a lot of what you think are pretty bad decisions. There's a number of things to do. Usually, if people are willing, there are a number of different organizations in this area that provide basically a driving assessment. And usually to kind of remove, because of course you can imagine driving is a really, really deeply ingrained part of everyone's life. And having someone come to you and tell you, you're not going to be allowed to drive anymore really rubs people about in as raw a way as possible. So I try to make it less about a judgment and less and more, particularly people who are earlier on, more about let's keep you safe. Let's keep everyone safe. Why don't you go and have someone who doesn't have a pony in the race to check you out? And if they think things are good, then we're going to just continue doing this until things change. Now, I have people coming into clinic who basically their families like this person is really, really unsafe. then either the primary doctor or someone like myself needs to have a discussion with them. Often, I found 9 times out of 10, most people, when they, un most people, at least in the moment, appreciate that they don't want to hurt themselves. And they don't, and even more importantly, they don't want to hurt someone else they don't know. And they will sort of agree, you know what? I've got someone who will drive me. My daughter will do this. My wife will do this. My nephew will do this. I can give up my keys. Every once in a while, I will call the Department of Motor Vehicles and basically ask them to reevaluate someone's driving privileges. This is only after multiple conversations. I don't want, again, I want people ultimately to have some agency over their own decisions. But at the end of the day, we need to keep the community safe. So that's usually how we deal with driving. Next question, how do patients get into the guide program? Um, one of one of really one way, and that how that way happens depends on the particular path you go. Patients need patients need to have basically two things. They need to have a dementia diagnosis, and they need to have Medicare B as their primary insurance. If patients have a dementia diagnosis and Medicare B as their primary insurer, then they can, when the guide program is up and ready for what we call aligning patients, those sorts of patients can be aligned. They can, if someone is being seen by a primary care doctor and the primary care doctor has diagnosed dementia, they can refer them to our guide program. Patients who we're seeing in our memory clinic are already being put on a list for alignment to the guide program. But that's basically the simple way is with a dementia diagnosis and the appropriate insurance, people can get into the guide program. And to answer that, the correlates will be available to all dementia patients at BSH. Unfortunately, no. There are some patients who are not on Medicare B and are on instead of different ACO programs. And CMS has right now said that those patients they will not spend the money for aligning those patients because the ACO should be doing something to take care of their dementia, even if they are not. Um, Next, how do we train the navigators? Good question. Um, we're working on that. In the past, we've sort of trained them on a ad hoc and very individualized basis. The Alzheimer's Association is working with a lot of different organizations to provide a unified navigator training around the country. And that should be up and running, I think, relatively quite soon because we're going to need to start training navigators literally in the next month. So that is, I think, that is how we are going to train our navigators. We're going to work with partner with the Alzheimer's Association of New England and use their training. And the advantage that that comes with is a certification that people have been trained by the Alzheimer's Association to do care navigation. Um, how cognizant are people that they are developing dementia? What a great question. And the answer to that question is that's really variable. One of the problems that you get in Alzheimer's disease, to a lesser extent in Lewy body disease, and you can certainly get this in vascular disease if the lesion is in the right place. There's a part of our brain called the mesial frontal lobes. The mesial frontal lobes are part of a larger system of our brain called the default network. The default network is basically what your brain is doing when you are quietly sitting in place, just kind of thinking or daydreaming. You're not doing a task, you're just sitting and kind of chilling. The default network is very critical for what we call our autobiographical knowledge of ourselves. And the default network is the network that basically lets me think if someone walked up to me and said, do you want to join us on a one-on-one basketball game? Well, I'm 5 foot 5 inches tall. You don't want me on your team. So the default network gives us an idea of what our capacities and capabilities are. And that network is often impaired in Alzheimer's disease. And it is not at all uncommon to see patients who have absolutely no real understanding or appreciation of their deficits. And here's the thing, and this is something I tell patients a lot. You can't argue with them. Arguing with patients who have Alzheimer's disease is a very futile thing to do. Because first of all, their short-term memory deficit ensures that they're not going to remember anything of the content of the argument, but because another part of their brain that remembers bad emotions is still working, they will remember that they were angry and frustrated. So you get all of the bad things of a bad argument with none of the actual information being trans transferred. Instead, what I tell people to do is try to live within their brain. And I try to explain what that brain looks like. And what that brain means is that the part of your body that allows you to sort of think about, oh my gosh, I don't have any short-term memory anymore. That part is basically disconnected from your sense of self. And we don't really have a good way of reconnecting it. We don't have a way of reconnecting it. So instead, you have to live with that person to know they're not going to know. So when they start to do something that they clearly can't do, and it's been a problem in the past, you instead have to pull out of your toolkit the great tool of redirection, which is, oh, let's do something else right now. And if someone we off, for example, someone with dementia will be at their daughter's home and say, well, I've got to go right now. My mom is waiting for me for dinner. And they get very upset if they can't go. Can't you drive me? So what we will tell people, you can't convince them that their mother has been dead for 30 years and that they actually live with a daughter. What you do instead is say, oh, well, let's get to that in a second. I just need to go to the bathroom. Run up to the bathroom, 6 minutes in the quiet, and the person will forget what they were upset about. And basically you can resume, and that's been washed away. So that's something which we see very, very frequently. Um, Let me see. Oh, what does CMS stand for? CMS stands for oh goodness gracious. Central Med something's it's either Consolidated or Central Medicare Services. Um, and guide is spelled exactly the way you spelled it. So if you Google guide and CMS, you should get something. Is guide modeled after European care? Sort of and sort of not. The Europeans, particularly the Dutch, are really good at doing kind of a super integrated kind of care. You've probably seen things on television where they're building, small communities, that are housing a couple hundred people in small, housing blocks of, 6 or 7 people that are basically kind of tiny versions of Longmeadow. And these are kind of areas where people who need housing, who are young, will live. And part of their housing comes from providing meal services and companionship services and a lot of other services to patients who have dementia. That's a great model, and it is incredibly powerful for the patients there. But we're not, that kind of model right now is just really not something that there is a groundswell of support for to make happen here, unfortunately. And hope we're hoping that that may happen in the future, but we're just not there right now. Let's see. Um, Let me see. Where are we? Sue, were there questions that are not on the Q&A?
Yeah, yes, there is. Thank you for asking. I just need to find. Oh, here we go. And I hope I'm saying this correctly. As low acet acetylchlorine levels often occur with Alzheimer's disease, and blood choline is a primary ingredient for acetylcholine production.
I I actually know
Might
what this question
Oh,
is, and
you do?
I know, and I have a I so this will take a few moments. So Alzheimer's disease impacts multiple neurotransmitter systems in the brain. Our brain uses quite literally a very complex soup of different chemicals to communicate. One of these chemicals is called acetylcholine. And it's been shown, some of the earliest data on Alzheimer's disease showed that a region of the brain that makes the acetylcholine that is basically squirted to different brain cells, and you can almost imagine kind of um, like a little, drip irrigation system, that the levels of acetylcholine go down in the brain with Alzheimer's disease. The issue is that choline is actually not really there's a huge amount of choline in our diets, and there's a huge amount of choline stored up in our bodies. Unlike certain nutrients, which are really trace micronutrients that potentially you could run out of, choline isn't one of them. Now, there's nothing wrong with taking choline. It's not going to hurt you. And the truth is, whatever you take that's in excess, you're going to pee out. That's okay. Your kidneys are happy to do that. But really taking it, there's been no studies that have really shown that taking choline supplementation improves anything that we've measured in Alzheimer's. Now, there's caveats. I'm going to caveat that by saying because choline isn't a really expensive drug, the studies have been done are relatively small studies that don't have the same kind of statistical power and the same kind of sophisticated outcomes that a study for an expensive drug like lecanemab might have. But that being said, we have not been able to demonstrate anything that choline by itself is able to is able to change. Other questions on the on that?
Yes, I have one more. We are a little over time, but if you're willing,
There's not a
would
lot
you
more
just like one?
questions, so I think we can get to everyone's question if they're
Brilliant.
patient and willing to just hang out.
Great. We have one more here. I understand that people with deteriorated blood vessels in the brain are at greater risk for blood bleeds, etc., when undergoing infusion treatment to slow Alzheimer's
Yeah,
disease. Is a
yeah.
person with deteriorated cardiopulmonary blood vessels at similar risk?
That's a very good question. I'm going to take a couple steps back to answer that question. So the risk that you're talking about is from these new anti-amyloid therapies that I haven't spoken very much at all about. These therapies are very, very specific for a very specific group of patients. These are patients who have either mild cognitive impairment, early dementia, and don't have a laundry list of other things that we go through in clinic. Now, when you talk about deteriorated blood vessels, there's different ways your blood vessels can get deteriorated. When you're talking about the side effect from these drugs, what the reason that that bleeding occurs is that the medication is designed to remove a protein that has kind of formed a gunk inside the cells, what we call an inclusion. It's designed to remove what are called amyloid inclusions out of the brain cells. And for what it's worth, for all the antibodies that have been developed, they are really good at removing these inclusions. The argument is once you've gotten the inclusions out, does it really make that much of a difference? The thing that comes out is that in some people, not all, although we can predict to some extent who the people who might have this problem would be and who might have a lower risk of this problem. In some people, not only is these amyloid gunks in the brain cells, they're in the walls of the blood vessel. And you can imagine in a drug that's really good at getting rid of these aggregates, if that protein is in the walls of the blood vessel of the brain and we rip it out of that blood vessel pretty quickly, you've got a hole. And that hole may just leak fluid. That's one of the side effects. But it could also, if that hole is big enough, leak blood cells. When you think about deterioration of blood vessels from a cardiovascular standpoint, we're more thinking about something like plaque, which is these fibrinous, in, basically residues that develop on the interior walls of the blood cell that are part fat, part different kinds of blood cells. That's a different kind of problem than the problem in the brain. So there's sort of two different issues. So when you give people the treatment, as far as we know, there's been no bleeding outside of the brain. You don't get much beta amyloid inclusions in the blood vessels that are in your neck, your heart, your lungs, your kidneys, your liver. You pick the place. For the exception of your brain, really, that's the only place you see these inclusions. So when people have the side effects, it tends to be bleeds in the brain. It spares the other parts of their body. Similarly, treatments for, we would call arteriosclerosis, they're great, but they're not going to change what's going on in the brain. They're not going to get rid of that beta amyloid in the brain blood vessels. Okay, next question. I'm going to kind of do them randomly, so if you don't hear it immediately, I will get to you, I promise. What is my opinion of the HOPE study? The HOPE study is basically the study where we're giving people a device that is providing them with a synchronized set of visual sensory input with the idea of basically synchronizing brain activity with the thought that with synchronized brain activity, we may be able to more appropriately preserve brain function. So what I will tell you is from a face validity standpoint, no argument. I think that that's a very promising idea. I haven't seen any of the Hope data yet, so I can't give you any kind of insider track about how are they doing. We have a couple of patients in our clinic who are enrolled in the Hope study, and my hope is that these are folks who were not able to get some of the other therapies. My hope is that this buys them something that our medical therapies could not do. Next, let's see. This is a little bit of a this is more of a comment than a question, but I think it's worth sort of mentioning. This is from someone who works in LifePath, and basically their their adult day program for caregiver respite is going to end this month because their grant basically sunsets out in June. And this is just grim because there's so little care of these sorts of programs anywhere. Um, and all I can say is, folks, if you are in that area, and even if you aren't, pick up your pens if you have a spare moment and send something to your assemblymen in Boston. Tell them that this is really important and that these programs are not that expensive and they are extremely valuable. They pay dividends. They don't pay them up front, but they pay dividends. Next question. Are there plans to incorporate social day programs into the system? Partially, the respite funding that Guide provides, by the way, it is limited. I did neglected to mention that. People only get $2,500 a year of respite funding with some small adjustment for geographical costs. But yeah, we can certainly use that money to buy increments of time in 4-hour chunks. So yeah, we could certainly Guide could certainly incorporate some adult day programs into their respite care program. Okay. Let's see. Oh, thank you, Amanda. Guiding an Improved Dementia Experience is the acronym of GUIDE. Thank you so much. If you can't get into GUIDE program, what's a good plan B? Depends. Um, you need to, where are you? I would ask, where is that person in terms of their voyage with dementia? Someone who is early on, where they're not going to be needing as many social supports, they may be able to get along with sort of more standard care. Guide is going to be much more useful as patients start developing more cognitive problems and require more care. And to be honest with you, there's not, I mean, it's really difficult to sort of find an organization that can do this on a sustainable basis under the current ways that we fund things. I mean, we try to do something like this in our clinic, but I can't because we don't have the money to cover the care team navigators' salaries. And that's something which is a hard lift to get at this institution right now. So I don't have a good answer for you that. I don't have a good plan B. Um, should someone who is screened with moderate dementia enter the memory clinic? Well, to get guide services, absolutely. Someone with moderate dementia is probably not going to get a tremendous amount of medical workup unless there's some kind of change in their behavior or in their status that's going to make you want to re-examine your your thoughts. I mean, someone who may have a new stroke or may be at risk for a bleed or has had a fall and may have had a subdural hemorrhage. Those are people who certainly are going to be seen in clinic. But as a general rule, at a certain level, we really focus much more on sort of providing care services and supportive services than more diagnostic services because the treatments to really we don't have treatments to other the care is, treating the depression, treating the behaviors are going to be done in that kind of context. But there's not a lot of workup that goes with that. Let's see. Last question. Um, has progress been made in penetrating the blood-brain barrier? Well, there's that thing that was on 60 Minutes about using ultrasound to try to do that. Hasn't been published yet, so I can't comment on that. I think it's totally possible that ultrasound could be used to do this. Remember, penetrating the blood-brain barrier sounds good on paper. There's a reason that the blood-brain barrier is there. And I would trod very, very lightly when we are talking about trying to get things to cross the blood-brain barrier in a more promiscuous fashion, because we know for sure that when people get delirious, one of the reasons they're getting delirious is almost certainly because in regions of their brain that blood-brain barrier is not working properly, and all sorts of chemicals that are in the bloodstream that shouldn't be getting into the brain cells are actually getting access there and causing a little bit of pandemonium. So I think there's progress, but this is one of those things where we would be very, very careful about how we use that progress because it could easily backfire on you in ways that are somewhat foreseeable. With that, I think we've answered the last question, unless someone has asked any more questions. Oh, how do patients get into the memory clinic? Two ways. Best way, get your primary doctor who is either Baystate or Baystate affiliated to drop a consultation for us. And then you will have a chance to have a wonderful conversation with Jamie Alaman Miranda, who does our scheduling and our work. And she is remarkable in every sense of the word. And that process will start. That's the best way of doing it. Um, we tend not, we want the primary doctor doing this because they're going to be giving us some information that we're going to need in order to figure out who's the best person of our staff to actually see a new patient. Anything else?
I think you've covered everything. And
Well,
thank
everyone,
you
thank you so
so
much.
much, the Chief of Geriatrics for Baystate Health, Dr. Bonasera. Thank you for your time and expertise and our audience for those great questions.
It's a pleasure. Thank you all. For all of you, good luck as you walk through this journey. It's very difficult, but there are people, at least in this system, we want to be able to help you where we can get through this.